Ascites Sarah Elseed, MD Ahmed Al-Dabdab, MD Basics Description: accumulation of fluid in the peritoneal cavity may occur in conditions that cause generalized edema. Refractory ascites, acidic fluid that recurs after paracentesis or cannot be prevented by treatment. Men generally have no fluid in peritoneal cavity. Women may have up to 20 ml depending on menstrual phase. Epidemiology: children, most commonly associated with nephrotic syndrome and malignancy. Adults, cirrhosis, 81%, cancer, 10%, heart failure, 3%, other, 6%. Incidence: 50–60% of cirrhotic patients develop ascites within 10 years. 1. The presence of ascites in cirrhotic patients is a poor prognostic indicator with a survival rate of 50% at 2 years. Prevalence: 10% of patients with cirrhosis have ascites. Etiology and pathophysiology: portal hypertension versus non-portal hypertension. Causes: cannot reliably establish/confirm etiology without paracentesis. Serum ascites albumin gradient, SAAG, serum albumin level, ascites albumin level, helps to differentiate causes. High portal pressure, SAAG greater than or equal to 1.1. Cirrhosis is the most common cause of ascites in the U.S. Hepatitis, alcoholic, viral, autoimmune, medications, acute liver failure, liver malignancy, primary or metastatic, elevated right sided filling pressures from heart failure or constrictive pericarditis, hepatic venous thrombosis, Budd-Chiari syndrome, portal vein thrombosis. Normal portal pressure, SAAG 1.1, peritoneal carcinomatosis, tuberculosis, severe hypoalbuminemia, nephrotic syndrome, severe enteropathy with protein loss, Meigs syndrome, ovarian cancer, lymphatic leak, chylous ascites, pancreatitis, inflammatory, vasculitis, leukocytosis, sarcoidosis, other infections, parasitic, fungal. Hemoperitoneum, trauma or ectopic pregnancy, pathogenesis of ascites in the setting of portal hypertension, cirrhotic ascites. Most ascites is due to portal hypertension leading to backward transmission of increased pressure to the visceral capillaries with subsequent dilation and shift of fluid to the peritoneal cavity. This dilation further increases portal pressures and decreases systemic blood volume with resultant hypotension. Systemic hypovolemia stimulates neurohormonal mechanisms, renin-angiotensin system and antidiuretic hormone, for sodium retention as an attempt to compensate for decreased systemic volume and pressure. Risk factors: cirrhosis, hepatitis B and C, alcohol abuse, congestive heart failure, CHF, advanced kidney disease, malignancy, tuberculosis. Diagnosis: history, address. Risk factors, example ETOH use, tuberculosis, TB, exposure, prior malignancies, sexual partners, transfusion history, metabolic syndrome, increased risk of non-alcoholic steatohepatitis progressing to cirrhosis, previous history of cardiac illness. Assess for symptoms of underlying disease: chest pain, dyspnea, orthopnea, peripheral edema, asterixis, weight loss, night sweats, chronic cough. Assess for complications: fever/abdominal pain might indicate spontaneous bacterial peritonitis, SBP, progressive dyspnea due to increased abdominal girth, progressive abdominal distension may be painful. Physical exam: abdominal distension with flank/shifting dullness is the most sensitive, 83%, and specific, 56%. Exam finding: requires greater than 1,500 ml of fluid to detect. Signs of right-sided heart failure suggesting cardiac cirrhosis: edema, penile/scrotal, pedal, increased jugular venous pressure. Stigmata of chronic liver cirrhosis: palmar erythema, spider angiomata, dilated abdominal wall, collateral veins. Other signs of advanced liver disease: jaundice, muscle wasting, gynecomastia, leukonychia, asterixis. Signs of underlying malignancy: cachexia, supraclavicular, Virchow, node suggests upper abdominal malignancy. Differential diagnosis: obesity, large ovarian tumors, bowel obstruction, massive splenomegaly. Diagnostic tests and interpretation: initial tests, lab, imaging, ultrasound, can detect small volumes of acidic fluid 100 ml. Diagnostic: paracentesis for fluid analysis to determine etiology and rule out infection in all inpatients and outpatients with clinically new onset ascites. Paracentesis complication rate is 1%. The presence of coagulation abnormalities does not preclude paracentesis, unless there is evidence of disseminated intravascular coagulopathy or primary fibrinolysis. 1. Routine attempts to correct platelet or coagulation defects not needed prior to paracentesis. Acidic fluid analysis. 1. C. Cell count and differential, polymorphonuclear, PMN, leukocytes greater than or equal to 250 cells/mm3 is diagnostic of SBP. Albumin to calculate SAAG, obtained by subtracting acidic fluid albumin from serum albumin obtained on the same day. 1.1 G indicates a low portal pressure exudative process, i.e., inflammatory, biliary/pancreatic, carcinomatosis, TB, greater than or equal to 1.1 G indicates portal hypertensive/transudative process, cirrhosis, CHF, constrictive pericarditis, thrombosis. Total protein, low in cirrhosis, nephrotic disease, and high in cardiac ascites, levels less than 10 gm/dl in cirrhotic patients without SBP indicate increased risk and warrant antibiotic prophylaxis. Other tests, based on clinical scenario to rule out etiologies other than cirrhosis. 1. C. Bacterial gram stain/culture if infection suspected. Cirrhotic patients with ascites can fail to mount fever or leukocytosis. Fluid cultures are traditionally positive in 50 to 90% of cases of SBP. Yield is improved if inoculated to blood culture bottles at bedside and if fluid is obtained before first dose of antibiotics. Amylase, suspicion for bowel perforation, cholelithiasis, or pancreatitis. Triglyceride if fluid appears milky. Cytology if concern for malignancy, less sensitive in the absence of carcinomatosis. Lactate dehydrogenase, LDH in acidic fluid. 2. Serum LDH ratio greater than 1.0 can indicate infection, perforation, or tumor. Carcinoembryonic antigen and alkaline phosphatase, elevated in viscous perforation, mycobacterial culture/polymerase chain reaction for suspicion of TB. Blood urea nitrogen/creatinine, electrolytes, renal function, brain natriuretic peptide, heart failure, liver function tests and hepatitis serologies. Hepatitis, abdominal ultrasound, US, can confirm ascites, highly sensitive, cost-effective, involves no radiation. Portal US Doppler can detect thrombosis or cirrhosis. CT scan for intra-abdominal pathology, malignancy, MRI preferred for evaluation of liver disease or confirmation of portal vein thrombosis. Diagnostic procedures/other laparoscopy, if imaging and paracentesis are non-diagnostic, allows for direct visualization and biopsy of peritoneum, liver, and intra-abdominal lymph nodes preferred for evaluating suspected peritoneal TB or malignancies. Test interpretation. Cytology may reveal malignant cells, adenocarcinoma, ovary, breast, GI tract, or primary peritoneal carcinoma, most commonly associated with ascites. Treatment for all patients. First-line treatment consists of daily weight restrict dietary sodium to less than or equal to 2 g/day if the cause is due to portal hypertension, high SAAG. Water restriction, 1.0 to 1.5 L/day, only necessary if serum sodium 120 to 125 milliequivalent/L. Avoid alcohol and ensure adequate nutrition if liver disease. Baclofen may be used to reduce alcohol craving/consumption in ETOH cirrhosis. Medication alert care with diuresis. Aggressive diuresis can induce prerenal acute kidney injury, AKI, encephalopathy, and hyponatremia. Monitor creatinine and electrolytes closely. Serum creatinine greater than 2 mg/dl or serum sodium 120 mol/L warrants withdrawal of diuretics. Avoid nonsteroidal anti-inflammatory drugs, can exacerbate oliguria/azotemia. Angiotensin-converting enzyme, ACE, inhibitors and angiotensin receptor blockers, ARBs, may be harmful in patients with cirrhosis/ascites due to an increased risk of hypotension and renal failure. Avoid in refractory ascites. Consider discontinuing beta blockers in patients with refractory ascites, SBP, worsening hypertension, SBP 90 mm Hg, ACI, hyponatremia 130 milliequivalent/L, or azotemia. First-line sodium restriction and diuretics are the mainstay of treatment for patients with elevated portal pressures. Other causes, example carcinomatosis, are less likely to respond to medical therapy. Spironolactone 100 to 400 mg daily PO, typical initial dose is 100 to 200 mg given in m. Diuretic of choice due to anti-aldosterone effects, can be used as single agent in minimal ascites. Monitor for hyperkalemia. Furosemide 40 to 160 mg daily PO, typical initial dose is 40 mg given in m. Antinatriuretic effect helps achieve negative sodium balance. Preferred in combination with spironolactone rather than as monotherapy, most common, and preferred, regimen is spironolactone and furosemide together, maintaining a 100:40 ratio, for maximum efficacy and to maintain potassium homeostasis. Titrate dose to desired result. 1. Daily weight loss no more than 0.5 kg per day in patients without peripheral edema and 1 kg per day in patients with peripheral edema. 2. Urinary sodium output more than the sodium intake, and monitor renal function regularly. Follow daily weight. Adjust ratio to maintain normal potassium. Diuretic intractable/refractory ascites, RA, 10% of patients 50% mortality in 6 months, defined as 1. Persistent or worsening ascites despite maximum doses of spironolactone, 400 mg per day, and furosemide, 160 mg per day, for at least 1 week. 2. Recurrence of grade 2 or 3 ascites within 4 weeks of achieving minimal ascites. 3. Diuretic-induced complications like hepatic encephalopathy, hyponatremia to 125 milliequivalent/L, renal impairment with creatinine rise of 100% to more than 2.0 treatment. Ensure compliance with dietary sodium restriction using 24-hour urine sodium excretion. Discontinue diuretics if urinary sodium excretion under diuretic therapy is less than 30 mol/day. Therapeutic paracentesis or serial large volume paracentesis, LVP, see surgery/other procedures. 4. Furosemide reduces eGFR dramatically in acidic patients and is better avoided. Second-line midodrine 7.5 mg TID can be used for refractory ascites or hypotensive patients. It was found to improve response to diuretics, improve hyponatremia, mean arterial pressure, and may improve survival. 1b. Titrate to blood pressure response. Alternatives to spironolactone, amiloride up to 40 mg per day, triamterene up to 200 mg per day in divided doses. 1. See alternatives to furosemide, torsemide up to 100 mg per day, bumetanide up to 4 mg per day. 1. C-vaptans may have a beneficial effect on hyponatremia and ascites, but routine use in ascites is not yet supported. FDA has recommended to avoid use in chronic liver disease due to potential to induce serious liver injury. 2a. Issues for referral liver transplant is the definitive treatment for portal hypertension. Consider referral for transplant in patients with decompensated liver disease, whether or not ascites is present/controlled. 1b. Surgery/other procedures. Therapeutic paracentesis, initial therapy if tense ascites is present. 1c. Serial, generally every 2 weeks. Paracentesis can be used as second line after diuretics in patients with elevated portal pressures. Complications: infection, hemodynamic collapse, Acute renal failure, similar complication rate as diuretics, replace albumin when removing greater than 5 L of ascites, 5.5 to 8.0 g albumin for each liter removed. Albumin replacement decreases renal dysfunction, post-paracentesis hyponatremia, and overall morbidity, likely not needed for malignant ascites. Continue diuretics at 50% of the previous dose if transitioning to serial paracentesis in patients failing diuretic monotherapy. Transjugular intrahepatic portosystemic shunt, TIPS, only for patients with elevated portal pressures with refractory ascites, fluoroscopically placed conduit from portal to hepatic vein for intractable ascites at time of placement. Portal pressure should drop greater than or equal to 20 mm Hg, or to 12 mm Hg, and ascites should be controllable with diuretics. Yearly US to confirm shunt function 4 weeks after TIPS, urinary sodium and serum creatinine improve significantly and can normalize after 6 to 12 months in combination with diuretics. Shunt dilation and or replacement may be required after 2 years. TIPS is superior to paracentesis for controlling ascites, no difference in mortality. Automated low-flow ascites pump drains acidic fluid from peritoneal cavity to urinary bladder for elimination. Mainly used in patients with contraindication to TIPS placement or liver transplant. Cell-free and concentrated ascites rainfusion, used for management of malignant ascites. Protein collected from filtration and concentration of acidic fluid is rainfused intravenously. Peritoneovenous shunt, LE-vene or Denver shunt drains ascites directly into the inferior vena cava. Trials show poor long-term shunt patency, no survival advantage. Complications include bacteremia, bowel obstruction, and variceal bleed. Reserved for patients with refractory ascites who are not candidates for TIPS or liver transplant and who can't tolerate repeat paracentesis. 1. C. Indwelling catheters with external drainage, most useful in malignant ascites as a palliative measure, can be drained at home. Overall low rate of infection. Avoid percutaneous endoscopic gastrostomy, PEG. Tube placement in patients with ascites due to high post-procedure mortality rate. 1. B. Ongoing care. Prognosis varies depending on underlying cause. Ascites in itself is rarely life-threatening but can signify life-threatening underlying disease, example cancer, end-stage liver disease. Complications. SBP, acidic fluid PMN leukocyte count greater than or equal to 250 cells/mm3 or positive culture. Broad-spectrum antibiotics are as follows. Cefotaxime 2-GQ8H or similar third-generation cephalosporin is the treatment of choice for suspected SBP, covers 95% of flora, including Escherichia coli, Klebsiella, pneumococci. 1a. Broader coverage often required for hospital-acquired infections. Levofloxacin is an alternative for patients who are not on long-term fluoroquinolones or who are allergic to penicillins or beta-lactams. Consider SBP prophylaxis in GI bleeding, previous SBP episode, or acidic fluid protein less than 10 g hospitalized for reasons other than SBP. Suspect primary bacterial peritonitis, PBP, due to bowel perforations when acidic fluid greater than 250 cells/mm3, often greater than 5,000 cells/mm3, and any two of the following. Acidic fluid total protein greater than 1 g/dl, often greater than 3 g/dl, acidic fluid glucose 50 mg/dl, or 2.8 mol/L, acidic fluid LDH that is threefold greater than serum LDH. Hepatorenal syndrome, type 1, rapid acute worsening of renal function evolving in the setting of a known precipitating factor. Type 2 is more slowly progressive in the setting of refractory ascites. Cellulitis is common in obese patients with brawny edema. Treat with diuretics and antibiotics.